Oh, Dr. Liana. Ni Dr. Liana.
Ya, saya. Sekejap saya tengah connecting to YouTube sekejap.
Dr. Liana. Betul lah. Oh, Dr. Liana. Ni Dr. Liana.
Ya, saya. Sekejap saya tengah connecting to YouTube sekejap.
Dr. Liana. Betul lah. Oh, Dr. Liana. Ni Dr. Liana.
Ya, saya. Sekejap saya tengah connecting to YouTube sekejap.
Dr. Liana. Betul lah. Oh, Dr. Liana. Ni Dr. Liana.
Ya, saya. Sekejap saya tengah connecting to YouTube sekejap.
Dr. Liana. Betul lah. Oh, Dr. Liana. Ni Dr. Liana.
Ya, saya. Sekejap saya tengah connecting to YouTube sekejap.
Dr. Liana. Betul lah.
Okay, Assalamualaikum. Dari Nazma dah join ke? Belum lagi
Belum lagi, tak nampak nama dia. Assalamualaikum, Aisyah. Selamat.
If
Okay, dah ada gambar ni tengah testing suara. Can see ya? Okay. Thanks. Tak, suara saya boleh tak? Kejap, saya nak bercakap lah ni dalam mikrofon ni, boleh dengar tak? Okay, kejap Boleh dengar ya? Boleh dengar tak ni? Saya cakap dalam ni.
Boleh dah.
Cakap dengan handphone
Boleh.
Okay, boleh dengar. We can hear you.
Boleh dengar tak?
Yes.
Boleh dah saya dengar.
Hello?
Hello. Lighting okay. Suara
Uh-uh.
datang.
Suara tak kuat ke?
Okay, clear Datin.
Ha?
Clear.
Clear ya?
So Datin nak test slide ke? Boleh.
Saya punya cakap dah boleh dengar eh?
Dah. Clear.
Dengar, okey.
Dengar? Kami dengar.
Okey, so test slide. So saya
Yeah.
buka slide saya ke you orang buka?
Datin buka.
Nak masuk kat mana tu?
Macam
Share screen Datin.
Yes.
lembek okey. Tempat lawi. Berseri. Apa baby dah masuk sebab infection.
Sorry, Datin pakai akaun mana? Saya nak upgrade jadi co-host. Datin?
Akaun mana? Ni
Mana?
Hashim Harun, Mam Hasumi ya?
Hashim Harun
Ya.
Okay, so saya make co-host. Okay. Then you should be able to share your screen.
Okay, so sekarang ni I buka the slide ke apa?
Betul.
Kejap ni nampak besar sangat. Kejap ya. Ya, I dah buka I punya PowerPoint ni.
Okay.
So macam mana tu?
Datin pakai device apa ni? Sorry.
Device apa?
Biasanya boleh
Dekat ni, desktop ni.
dekat desktop mana?
Uh-uh.
So share screen je.
Tekan share screen.
Betul. Ada tak nampak yang share screen tu?
Dia ada cakap, this will stop other screen sharing. Do you want to continue?
Yes, betul.
Siapa yang jemput tu?
Okay, dah nampak dah?
Yes, dah nampak.
Jemput.
Okay.
Minggu depan.
Okay, so boleh next Datin?
Ini
Ataupun
dia tak mau turun.
kena ataupun buat presentation Datin.
Presentation.
Betul.
Email apa?
Email apa lah?
Mana nampak?
Kita dia kata lepas Easter tu. Kata orang-orang kata suruh buat panggarik. Dia panggarik tu buat dah. Lepas tu Angau gitu semai-semai Easter tu. Ya kan ada. Tak ada tu makan keluar. Aku cakap-cakap masuk tu. Nah, Zoom ni tu muka.
Sorry Datin, saya termute tadi. Boleh Datin unmute yourself tak? Sorry. Nak unmute line tadi. Okay, we can hear you. So,
Mana? Slideshow.
yes, betul. So,
Okay, boleh nampak?
Menampak? Okay.
Okay, boleh.
Yes, okay, Alhamdulillah. Okay. Stop my mind.
Probably I'm saying it.
Um,
Ada apa-apa lain ke yang tak kena?
tak ada, I think okay dah Datin. So kita tunggu
Ya.
pukul 3 nanti.
Tunggu je lah.
Yes. Cuma nanti bila Cik Zamri,
So kalau yang masuk Q&A tu macam mana?
I understand dekat tengah-tengah slide ni ada announcement by Jadin Pharma kan Datin?
Okey, tak bila ada buka full screen ni ada tak boleh nampak yang undur.
Macam mana?
Bila I buat slide screen ni,
Betul?
yang kat belah bawah tu I tak nampak.
Oh you mean you nak presenter view is it?
Tak. Sekarang ni ada boleh gerak. Tapi kalau untuk yang question tu, I tak boleh
chat
nampak.
Oh datang dalam chat box. Okay, it's okay. Saya akan tengok chat box. Kalau how do you prefer nak jawab waktu hujung ke? Means nanti bila hujung tu baru saya akan bacakan soalan.
I think kita jawab kat hujung lah.
Betul, better that way so tak interrupt your flow of presentation kan? Okay.
Oh, tu.
Attention if any. Then
Already akan.
I can find and send so it can do. Kalau
Okay, Assalamualaikum. Assalamualaikum and very good afternoon, everyone. Thank you so much for joining this session. Thank you for being on time and welcome to our CME on eczema and psoriasis. Okay, eczema versus psoriasis, etiology, diagnosis and treatment. Okay, so this is the two most commonly encountered skin disease in primary care. Okay, first of all, I would like to thank our sponsor, Jardin Pharma, for organizing this event. And everyone, please wait for special announcement by our sponsor in the middle and towards the end of our session. Okay, so with us today, the guest speaker for this topic is Dr. Asmah Johar. Okay, a consultant dermatologist at Klinik Pakar Kulit Dahlia and Hospital Al-Zahra Bangi. Okay, without further ado, I will pass the session to Dr. Asmah. If you have any question, you can ask in the chat box.
Yes, Assalamualaikum and a very good afternoon. So I will be discussing on eczema versus psoriasis, on the etiology, diagnosis as well as treatment. So there are three aspects of comparison. The first one is how do we differentiate between eczema versus psoriasis based on the clinical types, the etiology, the risk and aggravating factors. And second, to how to diagnose eczema and psoriasis when it comes to the clinical differentiation, and whether we need to do any relevant investigation to confirm the diagnosis. And finally, we will look into the treatment for eczema as opposed to psoriasis. So what are the differences between eczema and psoriasis? When we look at the clinical types for eczema, they have two main types, that is endogenous and exogenous. So under endogenous, the common ones are usually atopic eczema, seborrheic eczema or seborrheic dermatitis. Occasionally, we do see discoid eczema or aesthetic eczema, papular eczema, nodular prurigo, and also more commonly hand and foot eczema. Now, the exogenous causes or due to the elements, okay, for examples are irritants or allergens, and therefore you get irritant contact dermatitis or allergic contact dermatitis. And if it is due to the ultraviolet light, then you can also get photodermatitis. For psoriasis, there are various clinical types commonly seen are plaque psoriasis, but you do get around the flexures, and occasionally you may see a pustular or erythrodermic type. Scalp is quite common. Can also get joint involvement or arthritis, and sometimes you can get nail changes. When we look at the etiology, both are actually multifactorial, and genetic is part of these factors. If we look at childhood eczema, if the parents do have history of eczema, then they have about 2 to 3% higher to have eczema, as well as in monozygotic twins. And there are genes which is located in some of these chromosomes, but at the moment we do not have treatment to actually help with this genetic problem, but we treat them by the clinical. And the predominant genes involved, okay, are your filaggrin, where this is important in the skin barrier. And also we have other genes that would encode all these other interleukins that actually play a role in the allergic inflammation. For psoriasis, genetic can go up to 70% and higher in monozygotic twins. And they also identify some genetic problem in psoriasis. It's just that we do not know why. There are some with no genetic can also present with psoriasis. So in atopic eczema, there is an interaction between these genes and environments. And when we talk about the immunology or two different types of atopic dermatitis, you have this extrinsic form, which can occur in about 70 to 80% of adults, and the intrinsic form, which is about 20 to 30%. And in the extrinsic form, they are easily sensitized to environmental allergens. And because of that, you can get raised serum IgE. But for the intrinsic form, they do not get sensitized to the environmental allergens. And because of that, you do not get any raised level of IgE. So because of the filigree gene problem, so you can get skin barrier disruption. So this is why a lot of the moisturizers nowadays highlight on the trying to improve on the ceramide or for the skin barrier problem. And sometimes you can get Staphylococcus aureus colonization, which can worsen the eczema. And besides that, there are all the other factors like increase in the pollution. And if you stay in a very confined environment, then you get more allergens like your house dust and the house dust mites. And also there are a lot of other that during modifications that may predispose a person to atopic dermatitis. Sorry, my slide is not coming down. Okay, so if we were to look at atopic dermatitis, between the allergic subtype and the non-allergic subtype, we can see that the interleukins plays a bigger role, causing all the inflammation, and less of this inflammation because the allergens are not actually playing much of a role. And therefore, in the non-allergic type, they are usually mild. So for psoriasis, what could trigger them? So psoriasis, if by cuts or scratching or surgery, you have what we call as Kopner phenomena, and therefore the psoriasis can worsen at the area. And stress can also worsen. Trivial infection or streptococcus infection or upper respiratory infection, for example, can worsen. Certain types of medication like beta blockers. So if the patient with treatment, it does not seem to be responding well, then we need to look at what medications they are taking. Okay, smoking, alcohol can worsen, and so we do not want patient to get sunburn because this might worsen their psoriasis. So if we look at psoriasis itself, there are a lot of cytokines or the interleukins, TNF. So these are all the areas where the biologics are nowadays looking at and trying to control psoriasis. So clinically, how do you identify eczema? So we know it is common, there is an inflamed skin, and the main thing is there is itchiness or pruritus. You should be able to see some red papules or erythematous papules, and in very acute stage, you can see all the vesicles. So these vesicles can later rupture. And the features may depend on the stage of the lesions, and I'll talk a bit later. As for psoriasis, it is also inflammation, and sometimes nowadays they want to say autoimmune, but still it is a chronic disease. If you look at this photo, it is well defined. You can see that the base is red, and you can see that the scales are quite thick, and they have these silvery scales. So, looking at the stages of lesions in acute eczema, as mentioned just now, you can get the erythematous papules, you can get the vesicles, and when these vesicles rupture, then you can get all the weeping, and they will form all the crust. So this is very acute. Now, there is a condition here because subacute, and in the subacute, you hardly have any vesicles. And in the chronic form, they are dry, they are a bit scaly, and we say lichenification, meaning the skin here is thin, and you can see that the skin marking are more prominent. So scratching will actually cause this lentification of the skin, and you also get pigmentation, either a post-inflammatory hyperpigmentation, or because of the scratching, sometimes you get post-inflammatory hypopigmentation. So in eczema, when we look at their age group, in infantile atopic eczema, around 2 months to 2 years, you can see that the areas involved can be over the scalp, the forehead, the cheeks, meaning on the face as well, and on the trunks, and also on the extensor surfaces of the arm, the elbow, and the knees. And as they grow older, you can still see all the patches, but if it is already chronic with a lot of scratching, you can get this lichenification. And the eczema will be more concentrated over the flexures, like the neck, the antecubital fossa, the popliteal fossa, and you can also get them over the wrists and the ankles. And as they grow older, you will find that the eczema can change a bit in the appearance. So then you find that, oh, they have hand and feet eczema, or they may have a papular form of eczema, or they may have a discoid eczema. And these are the areas that you may also find this eczema. So in order for you to diagnose atopic dermatitis, if based on research, then they will follow strictly on 2 diagnostic criteria. So the one is UK Working Party diagnostic criteria. So definitely it is an itchy condition, so you must have itchiness, and you can have 3 or more. So you can have a history of involvement over the skin tweezers, such as the antecubital fossa, popliteal fossa, dorsal ankle, a personal history of asthma or allergic rhinitis, the history of generally dry skin, visible fractional dermatitis, not just previous history, and usually the onset is under the age of 2. So the other criteria is called Hannepin-Rajka. So they have this major and minor. In a major, they must have at least 3. So pruritus is also still very important. They are chronic and they can relapse. Personal family history, typical morphology and distribution, and sometimes in adults you get their flexural. So you have all these either minor, including elevated serum IgE, nipple eczema, Psoriasis alba. So there are many others here, and the most common we know itch if they sweat, or some form of food intolerance. So these are the other criteria that can help you to diagnose atopic dermatitis. So what are the other types of eczema that we do see? So this is called discoid eczema. You can see they are like point shape, or sometimes we call it enameler eczema. And this is a bit more to the chronic side. In the acute stage, they can have the vesicles and they can be leaky. Another we call is pompolix. Okay, so there's the X missing there. And usually you get these vesicles or blisters on the palm and sole. So these are pompolix. And sometimes in the teenagers, you can get this juvenile plantar dermatosis, whereby you can see more of like a chronic form of eczema, not so much of the vesicles. And you can see this scale usually on the forefoot or the distal part of your palms. So in psoriasis, so how do we identify? You can see that here they are very red. This is very red. They are very well defined. And sometimes they can be like gutted part. There are so many. And if you look at the scalp, the areas involved can go beyond the hairline. So if this is your hairline and goes beyond the hairline. Okay, and if it is on the flexures, because of the moist environment, you hardly see much scales, but you can still see it is red and it is well defined. You can get nail changes like your fitting onycholysis, and sometimes you can get these plaque, but this one is just a thin plaque, okay, on the nail area, and below the nail area, you can get a periungual hyperkeratosis, and sometimes you may even see something like fungus, but actually it's part of this psoriasis, and you can see the arthritis here, and can at the same time see some joint deformity with a plaque here. So the other types of psoriasis, it can be erythrodermic psoriasis. So more than 90% of the body surface area are involved. And you can also have pustular psoriasis. And this pustular psoriasis, if it is very severe, it can almost involve the whole body. So are there investigations important? Okay. For example, in eczema, we rarely need to do skin biopsy because most of the time it is clinical diagnosis. And this is the same for psoriasis. Most of the time it is also clinical diagnosis. So you need to be able to identify between eczema and psoriasis clinically. For eczema, because they can be sensitized to environmental allergens, therefore you can do serum IgE. You can do a skin prick test, because when you do skin prick test, you're also looking at IgE. You can also do patch test if you think there are contact allergens that is worsening the eczema. And because of the scratching, and we do know that on our skin there are a lot of bacteria, you can get secondary bacterial infection. So sometimes you may want to do a smear, and sometimes they can have superimposed surface simplex infection. So this is where you do the zinc smear to look at giant cells, and sometimes you can do direct immunofluorescence. But zinc smear and direct immunofluorescence in a clinic environment may not be, you may not be able to do that unless you're in a hospital. For psoriasis, when we do skin biopsy, sometimes it's for those with pustules, because we need to differentiate whether they're having a subcorneal pustular dermatosis, or another one we call acute generalized exanthematous pustulosis, or we call it AGEP. So these are the other two differential diagnoses for pustular psoriasis. In eczema, so to make the diagnosis, finally, we need to look at the clinical features. Ask ourselves, do we need to do any IgE or patch test? Okay, and after that, try to meet up some of the criteria in either of the diagnostic criteria. As for psoriasis, it is mainly clinical diagnosis and only skin biopsy when you have pustules. So we'll take a break, and I would like to invite Mr. Zamri just to say a few things, and he will take up about 3 minutes. So, Pastor Zamri.
All right, thank you very much. Thank you very much, everybody. Thank you very much, MediaCorp, and also Dr. Asma for this session. And thank you very much also everybody, all the participants that spend the time for this session. I'm sure you find the session very, very beneficial and very, very enlightening so far. Right. So yes, my name is Zamri. I represent Jardin Pharma Berhad. All right. We are the parent company of Zorix. We acquired Jardin Pharma acquired Zorix since August last year. All right. What we would like to offer to all participants today, our starter pack, consisting of mostly of Jardin Pharma's product. We want to have let our participants today to have the best experience with our products. These are basically our some of the key products. All right. So in a starter pack consists of our Zozon, which is our hot selling, top selling aqueous cream, and also a recently launched product called Sensitive, which is actually a botanical product. approved by Medical Device Authority for treatment of atopic dermatitis, which consists mainly oatmeal and also pegaga, or all right, it's locally known as a pegaga. Also, we also giving away this free COVID-19 test kit, and also 3 types of betamethasone, our hot selling betamethasone also, which is our Zosson 1-2, Zosson 1-4, and also Zosson 1-10, right? Okay, and also we're giving away free Zyside, which is our hand sanitizer, right? And it also comes together with a calendar, and also comes with a free paper bag as well, right? So we would like to encourage all participants today to scan the QR code. You can see at the bottom right corner there. All right, there is basically is a QR code to sign up for our portal. It's called Herbitus. This is actually a portal developed by Jardine Pharma. Actually, it will create a win-win situation for both Jardine Pharma and also our customers, right? Whereby the participants can register as a member and also as a merchant, whereby you can advertise your product and services in that portal. It's called Herbitus. So feel free to scan QR code, register as a merchant, and for all successful registration, we will give away the starter pack as you can see on the screen right now. All right. So if there's anything, you can contact us at our care line 0377347155. Or feel free to WhatsApp and contact my mobile 012-329-4892, and my name is Zamri. I repeat, my mobile number is 012-329-4892. My name is Zamri. I represent Jardine Pharma. All right, thank you so much. All right, I see you again at the end of the session. I'm handing over back to Dr. Asma. Thank you.
Okay, thank you very much, Encik Zamri. So we'll carry on. Okay, so next would be on the treatment for eczema as opposed to psoriasis. So for the management, whether it is eczema or whether it is psoriasis, the strategy is to provide education and support. For eczema mainly, that is to avoid the allergens, and for both eczema and psoriasis, to look at what are the factors that can aggravate this problem. You need to have some form of skin care, and moisturizer is very important, especially for eczema. But for psoriasis, also because of the scaliness and the dryness, the moisturizer is also very important. And specific treatment for eczema, for example, your steroids, or your calcineurin inhibitor are important. And in psoriasis, the anti-inflammatory may be steroids or may be calcipotriol. So we need to control the pruritus, especially for eczema, because they are very itchy. So we'll tell a bit more on how to control the itchiness. And we also need to do some form of prevention so that you can reduce the severity, you can reduce the flare, and you can also need, sometimes to treat for the complications so that it does not worsen the skin problem. So the mode of therapy for both, we have topical, systemic, as well as phototherapy. So for now, I will look into atopic eczema first, because it's a very big topic. So atopic eczema, treatment-wise, if it's topical, you have your oral. Sometimes you can do wet wraps if it is very severe, and a counseling. So these are some of the things that we often do in the clinics. And when we look at the first line treatment, basically it is topical steroids and moisturizers and antihistamines. So all these three in combination is actually enough or effective in more than 95% of cases. So you don't really need to go to the second line, which needs sometimes wet wraps or phototherapy and systemic agents. But nowadays, phototherapy is actually included as part of a systemic agents. So what are the treatment for the topical? So in eczema, topical is the mainstay of treatment, not the oral. So emollients, why is important? Okay, we want to keep the skin hydrated because you can get transepidermal water loss. Okay, best to be applied after bath when the skin is still moist, especially if you want to use an ointment form like emulsificants or Vaseline. You need to retain some moisture, so you need to do it after bath. Yeah, you can also use things like aqueous cream. So this is the most basic, but now we know there's so many other types of moisturizers. And if you want to use urea cream, be a bit careful. If there is any excoriation or skin fissure, it can sting. So you can use urea cream, but be careful if there's a lot of excoriations. So when the skin lesions are very deeply, so you need to use astringents, and most of the time we use either potassium permanganate or normal saline. So when you use potassium permanganate, please make sure you dilute properly because you do not want to irritate the skin. And sometimes you can do soaking. We can also do continuous wet dressing. And if it is over the buttock area, you can even do a sitz bath. So what are the topical steroids that is commonly available? So if you were to look at the British National Formulary, they classify the topical steroids into 4 different potency: very potent, potent, moderate, and mild. But under the United States or USA, they have 7 classifications. So you can have a look at both, okay, but I usually use the British one. And please take note, okay, when it is in an ointment form, it is more potent than the cream form. Okay. So what is clobetasol propionate? Some of the examples, I'm sure you know, the original brand is the Movit, so that is clobetasol propionate. And you have a lot of other generics. So if you have beclometasone dipropionate, they are under potent. If you have betasone valerate, I say BVC, okay, 0.1% is actually a full strength. Okay, it's not 1%, it's 0.1%, and that is full strength. Okay, and you can also have betasone dipropionate. Okay, this is quarter strength, this is half strength, but still under potent. And we do see sometimes hydrocortisone butyrate being used. More metasulfurate that is commonly used. You have your original brand, your element, and you also have other generics as well. And you can have transneuron acetonide. Most of them, this is generic, okay. And when you come to moderate, so if you look at the betamethasone valerate, 0.1% is full strength. And when it comes down, okay, to quarter strength, it is already moderate. Okay. Clobetasone butyrate. So you look up here, this is clobetasone propionate. This is the strongest steroid, most potent. But when it comes to clobetasone butyrate, this is already a quarter strength. Okay, it's like a quarter strength steroid or almost a similar strength, half strength steroid. So what is some of the brand that we know is things like Euclosone and the O. So these are the common steroids that we do see. And of course, for babies, the most commonly used are hydrocortisone acetate. Okay, so if you look at here, you have the other hydrocortisone is butyrate, okay, 0.1%. So this is potent. And you look at here, hydrocortisone acetate, 0.1%. This is mild. Okay, so do not get confused because depending on the age, depending on the site, depending on the severity, you need to adjust the steroid potency. So just to show how, okay, for example, okay, like Zosson, this is 1 in 10. Okay, so 1 in 10 is actually 0.01%. Just now I say 0.1% is full strength. Okay, so Zosson 1 in 10, okay, and also 1 in 8, so it's 0.00125%. So this can be used in children and babies. And if you need something slightly stronger, you can use the quarter strength, 1 in 4. So this is 0.025%. Okay, Okay, and if you need like maybe an older children, the teenagers, you can use half strength, 0.05%. Okay, and if you need an ointment form, so either you choose the cream or you can use the ointment form. But always remember, even though it is 0.01%, it is full strength. But when it comes to ointment and cream, ointment is slightly more potent because of the occlusion caused by the ointment. Okay, so in acute eczema, now we need to use astringent. So on the other parts of the body, we can use the potassium permanganate, but avoid on the face, okay, because we do not want to irritate the eye in case it splashes into the eye. So this I mentioned just now. So if you look at how to do, okay, continuous wet pressing. So you need to dilute, okay, your potassium permanganate, this color. And if let's say after several usage, you find that the skin becomes brown, then you know that you have actually used a bit more concentrated. So you need to dilute. And you can have a spray, you can also have a linen. So this is to be fast. The good thing about using to be fast like this, then you don't have to use a plaster. Okay, so it is stick to the skin, and every 1 or 2 hours, you can just spray back. And if this color become brown, it's already oxidized, so you will have to mix a new batch. So the other treatment, okay, you can see this non-steroid option for eczema is your calcineurin inhibitor. So you can have 0.1% for adults and 0.03% for children. Okay, and what happened is that it can help to control, okay, the eczema, and sometimes it can also prevent relapse. But it's a bit slow, so you need about 1 week to actually see more improvement as opposed to topical steroids, okay, and you can use it safely. The only problem, sometimes you may have a bit of burning sensation or a bit of pruritus. Okay. And for the other one, that is P-macrolimus. So when do you use P-macrolimus? When do you use tacrolimus? So P-macrolimus are for mild to moderate eczema, and tacrolimus is for moderate to severe eczema. So if you find that the patient, okay, is in the moderate group and not responding to your P-macrolimus, then you have to upgrade and use tacrolimus. Okay, so you can use P-macrolimus long term to actually help reduce the inflammation and also to prevent flare. So next is psoriasis. So what can we use for psoriasis? Now in the government hospitals, okay, or sometimes in university, you have a lot of tar preparation. They use either a full tar or a refined tar. For example, like liquid physis carbonates, LPC. This is a refined tar. It is used as a first line. Topical steroids, don't use the very potent one. It is used for specific areas of face and flexures, okay, because you do not want to have any thinning of the skin, so don't use potent one. And sometimes the tar can irritate these areas, so that's why certain areas you have no option but use topical steroids. Okay? In the hospitals, they also have ditronol, and they can use also keratolytics. We can also use keratolytics. So which one do you need to use? Is the 2%. Okay, don't use the 5%, use the 2%. So where do you use the 5% salicylic acid? Only on the palm and sole, because these areas are thick. But on the other parts of the body, just use 2% salicylic acid. Why we put salicylic acid? And that is to remove a bit these thick scales so that your other topical can penetrate better and control the psoriasis. And you also use emollients. You can use cream or ointment. And calcipotriol is more expensive, but they have now with or without steroid. So in private, it may be your first line. But in the government hospitals or public universities, it may be tar as the first line. So it depends on the group of patient, okay, and whether they can afford calcipotriol. So calcipotriol, what are the well-known brand? Okay, your Diamonex, your double bed. And double bed now they have a lot of preparations. They have ointment, but they don't have cream. Okay, they have Zemiol for your scalp, and latest they have Eczema foam, okay, which can use over your scalp and also the body. But Eczema definitely is more expensive because it's 60 grams as opposed to Divobite or Divonex, those are 30 grams. And whether they will be generics or they already are generics now, I'm not very sure. So when we compare on the systemic treatment requirement, okay, for the more severe cases, antihistamines, okay, oral, we often use. Psoriasis, because most of the time it is not itchy, but maybe because in Malaysia it's more humid, so sometimes it's a bit itchy, so sometimes we do use. Atopic dermatitis, okay, we don't use corticosteroid for months and months. We only use in acute severe cases, just a short course. Okay, and for pustular psoriasis, so sometimes you can use a systemic steroid. So what about phototherapy? Atopic dermatitis, you can use Neuroben, you can use PUVA. PUVA means UVA, VP is Soralan, okay, or just localized UVA. And these are for the more severe or recalcitrant ones. For psoriasis, we can use the same phototherapy. Here means retinoid plus Soralan and UVA. So you have to have the phototherapy habit in the center. Cyclosporin can be used for both. Methotrexate rarely used in atopic dermatitis, but commonly used in psoriasis because it's so much easier to give, just once a week. Azathioprine are given more in atopic dermatitis, hardly given in psoriasis. Retinoids, again, not given in atopic dermatitis, but acetretin are commonly used in those more severe psoriasis, especially for those with pustular psoriasis, extensive psoriasis, or erythrodermic psoriasis. And both also nowadays have biologics for the severe disease. So when we look at biologics, okay, the commonly used now are dupilumab, okay, but of course we know it costs thousands for just a year treatment. Okay, so dupilumab, looking at the JAK inhibitor of here. Okay, and for psoriasis we have a lot. Okay, so these are the list of biologics for psoriasis, and they also use biologics to control psoriatic arthritis. Okay, so they will look at all the pathway and where are all the biologics involved, whether interleukin 12, interleukin 2A, the TNF, or interleukin 17A. So back to atopic dermatitis. So we must maintain skin hydration. You can bath or shower once or twice a day, and not too excessive because you will dry up the skin. You can use mild soap substitute, or nowadays you have a lot of cleansers basically for eczema, so you can use that as well. You can use the moisturizer, best aftermath. Okay, and if the skin is dry, you can also use moisturizer. If you want to use at bedtime, fine, but if the skin is already very dry, moist the skin first before you put the moisturizer. And it is important to maintain the skin hydration because it can help to reduce the itch and improve the skin barrier. So we also need to address itchiness because we want to break the itch scratch cycle because it will worsen either the eczema or even psoriasis. Okay, so avoid scratching and astringents if it is very weepy. So these are the form of skincare. Okay. So let us look again at what are the available, the most basic ones. Okay, you have a lot of other, sometimes they use the word therapeutic moisturizers, yeah, because they add a lot of other ingredients. But we just look at now at the most basic one, okay, aqueous cream. So we know this very well. And sometimes we even use the aqueous cream as soap. Okay, if the usual soap stinks, then we use aqueous cream as soap and moisturizer. So meaning bathe with aqueous cream and after that put back the aqueous cream as a moisturizer. Now sometimes you find that the texture is maybe a bit too light and drying very fast. So we add glycerin. So there are two percentage here that you can use, 25% as well as 50%. So glycerin, you know, is a good humectant, and when you put in the aqueous cream, they're a bit more greasy or a bit more oily, because sometimes you do not want to use Vaseline. Okay, so you do not want to use Vaseline or emulsificant. Okay, emulsificant, because they are a bit too oily, and then they stick all over your clothes and all your other equipment, so you don't want to use the ointment. So these are the other two options that can use. Okay, 25% or 50% glycerin. Okay, so this is also ointment. Okay, now as I mentioned just now, you can use urea cream. Okay, urea cream usually is 5%. But if there is excoriation or there is a skin fissure, don't put the urea there because it will sting. Okay, you can also have even a higher concentration. So the other one that we sometimes use is wet wrap. So you can buy this to be fast. Okay, so the first layer is moist, and the second layer, when we turn it and pull it up back, is dry. Okay, but before we can put this wet wrap, we need to put some creams. Okay, so what creams do you put? You put two. Moisturizer, you can put aqueous cream or any other moisturizers, but don't use the potent steroid. Okay, because when you do wet wrap, it's already moist and you get better penetration. So you can use hydrocon, or you can use a betamethasone, 1 in 4 or quarter strength, or maybe just half strength, but not for babies, maybe for the older age group. So this wet wrap is for short term. So you do not need to go beyond 1 week to do wet wrap. Sometimes you just need about 3 to 4 days just to control. It helps the skin hydration, okay, better absorption of the topical steroid. So don't use too potent. Okay, and also a barrier prevent the child from scratching and worsen their eczema. So in eczema, because of all the scratching and sometimes cause the colonization of the staph aureus, so you may want to treat if you suspect that is impetigo or is all infected because of the scratching, got fissure infected as well. And sometimes, okay, if it is, you can see that the infection is not localized, but more generalized, then do not hesitate to give us systemic antibiotics, and your focus is for your staph and your strep. Okay, but sometimes you must remember MRSA also now exists in the community. So if it does not work that well, then you may have to think whether there is MRSA or not. So what about diet? In atopic dermatitis, okay, there are those allergenic to cow's milk, eggs, seafood, tree nuts, peanuts. There's so many. And then among children, it can be as high as 5 to 8%, 1 to 2% in adults. So you can do the serum IgE. We don't have food challenge in Malaysia, but obviously they do food challenge. Okay, and sometimes we need to do this serum IgE because we do not want to tell the parents don't take almost like everything, so they will be malnourished. So we want the children to have a good nutrition. And is there a role of supplements? Somehow throughout the years, previously they used to say, okay, use a high dose primrose oil, but now that is already out. And after that, they say, okay, why don't you use a probiotic? So sometimes it helps, sometimes it may not help. Same like in any of the research, sometimes it helps, sometimes it's not helpful. So if they can afford, you want to give it a try, so that is no problem. Okay, so I think the latest nowadays they're thinking about is probiotics. Okay, so with that, I thank you. Sorry, I'm not able to go into too much detail because these two topics are actually very big topics. So thank you again.
Okay, thank you, Doktor. Saya bacakan beberapa soalan yang ditanya dalam chat box. Okay. Okay, ada yang bertanya tadi, is there any specific food that will cause flare? in patient with eczema?
Okay, so we know that in eczema, they can be sensitized to environmental allergens. So environmental allergens include food allergens. Okay, so in children, okay, usually we have these 6 common food allergens. Okay, for example, soya, wheat, peanut, fish, okay, cod fish. Okay, so if you are familiar with IgE, they will list this. Okay, milk and okay, soya, wheat, and egg. Okay, so these are the 6 common allergens. Okay, and when the child grow older, okay, then we will be introduced, of course, in Malaysia or Asian country, a lot of seafood. Okay, so it can be seafood allergens. Seafood allergens not talking mostly about fish, but we are talking about the squid, the crab, you know, the shellfish, yeah, and also crabs, okay, clams. There's so many types of clams, okay, and sometimes we get introduced to a lot of not peanut but tree nuts. So there is a higher incidence, okay, of allergic reaction in tree nuts. For example, almond, cashew nut, so those are tree nuts. Yeah, now of course you can have other allergens like chicken, beef, you know, so these are the common food allergens. Next question.
Okay, thank you. Okay, another good question is on oral antihistamine for children less than 2 years old. Okay, what are the recommended option for to treat the pruritus? Because it is not recommended to give oral antihistamine for children below 2 years old.
Yes, the recommendation is not to give antihistamines. Okay, so let's say you cannot give antihistamines or you want to follow strictly no antihistamines if it is less than 2 years old. So what can you do? So you need to control the eczema fast, because itchiness is a sign that the eczema is active or not under control. So sometimes you need to use the steroids that is slightly more potent. You don't just use hydrocortisone, it will not work. Okay, so you may have to give the more potent one so that you can control fast, and therefore you will be able to reduce the itchiness fast. And number 2, make sure you apply the moisturizers. Okay, don't say, okay, use this steroid for 1 week, and after 1 week, then only use the moisturizer. Okay, so you need to use both at the same time, because we know in eczema, there is a problem with the skin barrier. And some of the moisturizers, we are not talking about aqueous cream, okay, there are other therapeutic moisturizers. They have other ingredients, okay, that will actually help to improve the ceramide, which is important in the skin barrier. Of course, you can use the wet wraps and all, or the soaking with this very, very whippy. So all this will actually help to control the eczema. So control fast if you cannot give the antihistamines. But if it is very severe, in a sense, you see a lot of excretions, get a lot of secondary bacterial infections, you can give, but give a very short course. Okay, maybe just 2 days or 3 days enough. Okay, and observe carefully. Okay, and maybe you can give a slightly lower dose, you know, because sometimes it's important. Why? Because you just have to stop them from scratching. But use this other technique first, okay, so that you don't have to use antihistamine. Next question.
Okay, and next question about the topical therapy. So if we are to apply both emollients and corticosteroid, which one do we put first?
Okay, now in atopic eczema, we know generally the whole body is dry. Okay, so that is where sometimes the advice comes, put the moisturizer first. Okay, so for an adult, you need like 30 grams for the whole body. So for a child, it will be less than that. So that is per application. So you may need about 15 grams, okay, for the whole body in a child. And so if the skin is dry generally all over, then you put the moisturizer first. The only problem when you put the moisturizer first, okay, if you forget where are the eczema areas, so those eczema area where it's a bit mild, you cannot identify already because all you can see is already moist. Okay, so you need to remember where to put the topical steroids after using moisturizers. Now, sometimes you have patients where you don't really need to put the moisturizer the whole body. Okay, so for that, I like to put the steroid creams first, then put the moisturizer. Why? Because you can imagine early in the morning, going to school, the parents going to work, they don't really have time, to put everything, follow strictly. So sometimes you have to adjust a bit. So you can put the steroids first, at least you can see where are the areas, problematic areas, and sometimes you need to put a bit of the topical antibiotic, then you put the moisturizers very fast, so that you can really concentrate on where you really need to put the steroid creams. Next question.
Okay, so next question, there's few questions about the role of a steroid in psoriasis, when it is recommended to give steroid in psoriasis, and also is it recommended to give intramuscular steroid for psoriasis?
Okay, now for topical steroids in psoriasis, okay, you have to choose the area, and this area is because you cannot use the others. You cannot put the tar, you cannot put the calcipotriol because calcipotriol can irritate. You cannot put the erythritol because it can irritate. So you end up with topical steroids on the face or the ear or the axillary area or the groin area. Okay, so but don't use potent steroids on these areas because you know they will thin out very fast, and if you do that, you will end up a lot of stretch mark. So avoid using the potent. So sometimes you have to adjust between the BDC 1 in 10, 1 in 4. Okay, rarely use the steroids 1 in 2 or above. Rarely. Okay, so just use the less potent ones or up to the quarter strength steroids. Okay. So is it advisable to give intramuscular steroid for psoriasis? Okay, the answer is no. Okay, because it is advisable to use the other oral systemic agent. When do we use systemic steroid? In situations where, for example, erythrodermic, pustular psoriasis. Okay, because if you start using steroid, at the end of the day, you do not know when to stop. Okay, and you will end up a lot of systemic steroid side effects. And sometimes when you give intramuscular steroid or systemic steroids, you can make their psoriasis become unstable. So instead of just plaque psoriasis, after that you'll be dealing with pustular psoriasis or erythrodermic psoriasis. So that is why you must avoid using systemic steroids. Next question.
Thank you. Okay, so next question is about eczema. There's 2 questions. Okay, first, this hydrotic eczema can be frustrating to treat as it is can easily recur. What is your advice? This hydrotic eczema. Second question is something
I can hear the dyshydrotic eczema. What's the question?
Can be frustrating to treat as it can easily recur. What is your advice on the treatment to prevent the recurrence of dyshydrotic eczema?
Okay, so for dyshydrotic eczema, if you have a lot of vesicles, okay, or bully, then you need to use the astringents to cool down, to dry up lesions. And a lot of time you will have to end up using the more potent steroids. Okay, so the more potent steroids, you have to know what is the duration that you can use. Okay, for example, you want to use clobetasol propionate, so it's the most potent. So our advice usually is don't use beyond 2 weeks. So what happens if you have to use beyond 2 weeks? Okay, then you have to go to tacrolimus. Okay, so the calcineurin inhibitor for the moderate to severe. So sometimes you have to alternate, Okay, once you put the tacrolimus and then flare up again, then you put back the clobetasol propionate. So you have to alternate. So that is the only way. But of course, at the back of the mind, okay, for the other form of eczema, sometimes it may be associated with food allergy. Okay, so you may have to look into that problem. Or sometimes if you have like a hand or feet, you can see the vesicles. You have to ask yourself, is it an heat reaction? Okay, to a tinea interdigitalis. Okay, you can have this ethnic or the Singapore food, or you can have this fungus infection. Okay, at the fourth, or the third or the fourth toe wet space. So this sometimes can induce a reaction, and you can see these vesicles on the palm and sole. So if they are like 45 years above with diabetes and all, please consider that as well. And also, don't forget to put moisturizers. So the moisturizers you have to use very often. So it not just like after bath, yeah. So it has after meal, after washing, any form of wet work after that, they will have to put the moisturizers. Okay, so that will actually help. And antihistamines.
Okay, thank you.
Question.
Next one, what is your advice to the general practitioner, means primary care doctors? When is the right time to refer this patient to specialist clinic? Okay.
Okay. So you know the most basic treatment, okay, for eczema, we know, okay, for example, atopic eczema, there are three main ones that you need to use. Your first line, your steroids, your moisturizers, your antihistamines. Okay. So if you think if you cannot control, then ask yourself, is there infection? Okay, so sometimes you may treat the infection, but if the patient does not respond, okay, by the second visit or the third visit, or there is worsening, then you can refer to the specialist. So what is it that you might be missing out? Okay, you might be missing out maybe the contact allergens that the patient is exposed, maybe the food allergens that the patients are exposed. And so sometimes some people, they like to do the IgE, but you must be able to advise them, okay, on how to avoid these allergens, because it's just not enough doing the test and giving the patients the result, and after that you do not counsel them on how to reduce all this allergen exposure. Okay, so if, and of course along the way it becomes very severe, then definitely you have to refer to the dermatologist, because you will need either phototherapy, so that will be hospital based with phototherapy cabin. Not everybody has phototherapy cabin, or you have to start with systemic agent, and when you start systemic agent, you know there will be a lot of monitoring, the blood monitoring, make sure the x-ray is fine, there's no pneumonia, and then sometimes they will have like in between severe infection, you know. So I don't think you want to deal with those kind of problems. So if you think they need an oral treatment, then you refer to the dermatologist.
Okay, thank you. I think this will be the last one. Okay. Doctor, does COVID vaccine really worsen eczema? Is there any evidence so that we can counter whatever the patient is punya complaint lah?
Okay, so now you see the thing is the vaccine, okay, we have the last we received the vaccine, okay, most of the time I think most patients stop at the booster. So it's already quite some time already. So it's like I think almost reaching, some maybe 1 year, some maybe more than 1 year already. Okay, so we actually are out of the space already. So the earlier phase, you know, I find that in my clinic itself, okay, I do see a lot of them, okay, having the eczema about 2 or 3 weeks later after the vaccine. And sometimes a bit more delayed, 6 months later. And sometimes I find the eczema was there, but it was not properly treated, and therefore it is dragging for the next 6 months to even 1 year. Okay, but now we are actually over those vaccine problem. And if you are to look and even to attend any of the congresses, you know, you will see that there are a lot of some side effects, okay, a lot of side effects, not just to the skin, but to the other organ when it comes to the vaccine. So we just need to go back into the history and see whether it started, okay, from the vaccine or not. But for eczema, there's no problem. You don't have to worry. You just treat the same way. Okay, it's just that sometimes if you detect early, then you need to be a bit more aggressive, use the more potent steroids. Okay, but otherwise, you just treat them as usual for any form of eczema. Because I do find for vaccine, sometimes they just, for first time they have eczema and we put treatment and they're better. But sometimes because they have childhood eczema, and after the vaccine, the eczema appear, and after that we treat, and they manage to be controlled. So far, I've not actually seen those that is not controlled, okay, for the eczema. Any other question?
I think that's all with the limited time we have. Okay, so thank you so much, Dr. Asma, for the session. We find it really beneficial. Okay, I look forward for another session by you in future, inshallah. Okay, just a reminder for all participants. Okay, please submit the feedback form for CPD point submission. Okay, and I'll pass the session to Encik Zamri, our sponsors again.
All right, everybody, I'm back. Hello. All right. Once again, I'm Zamri. I represent Jardin Pharma. All right. Jardin Pharma is a parent company for several companies. One of them is Zorix in Berhad, which is a very established manufacturer of a dermatological range of products such as aqueous cream, zinc oxide, betamethasone, and several more. All right. Okay. I would like to ask all participants to give a round of applause and show our appreciation to our speaker today, Dr. Asma Johar, for such a very enlightening, enriching, and beneficial presentation today, Datin. Thank you so much, Datin. I truly enjoyed your presentation. It's very, very enlightening. Right. Okay. So, right. So for participants today, we would like to, give away our starter pack, which consists of 9 items, which is our Zosson 1-2, Zosson 1-4, and also Zosson 0.1, which is our betamethasone 0.05%, betamethasone 0.25%, and also our betamethasone 0.1%. All right, we're giving them away free of charge together with our aqueous cream, all right, which is our hot selling product, together with our quite recently launched product called Sensitive, which is actually a skin barrier therapy approved by the Medical Device Authority for the treatment of atopic dermatitis, which is the key ingredient consists of oatmeal and also pagaga or Centella acetica, is scientifically known, right? And we're also giving away our Zyside, which is a hand sanitizer. And also we're giving away our COVID-19 test kit, and we're giving away a calendar. It looks like this. It's not just ordinary calendar. Yes, it tells a date and day at the front, but healthcare practitioners, right, will find this calendar very, very useful because you can use it to explain to the patient, this level of severity of their condition and the treatment that you will recommend to them. All right. So you find this very, very useful. All right. So you can do so by scanning the QR code. All right, the QR code at the bottom of the screen, you should be able to see it. Dr. Ileana, will you be able to share with us the QR code again? Perhaps the next slide.
Sorry, I don't have control over the slide right now. Okay.
Can we go back to yes, that's the one.
Okay,
yes,
thank you.
Okay, thank you so much. All right, there's a QR code to register for today. All right, this is to register for our portal. It's called Herbitus. Herbitus is a portal developed by Jardin Pharma. All right, for healthcare professionals, business owners, to register as a member and also as a merchant, whereby they can advertise their product and services there as well. So it'll be a win-win situation whereby the merchants, the business owners can can register and benefit from the the privileges and advantages for being a member and also as a merchant there. All right. So feel free to scan QR code at the bottom right of my screen, all right, to get this free starter pack, as I mentioned to you just now. All right. All right. So otherwise, feel free to call our hotline number at care line number is 0377347155, or you may call or WhatsApp myself. My name is Zamri. I represent Jardin Pharma. My mobile is 0123294892. All participants should be able to see at the bottom of the screen as well. All right. And one last thing, perhaps I noticed there are several more questions were asked at the end of the session or so. All right. So for those who are unable to get the question answered, I would strongly recommend perhaps you can forward to myself, all right, or Dr. Iliana, the organizer today. Perhaps we can try to forward to Datin Asma for her maybe to get back to the rest of the participants. Right. So let's give them a chance also to get a question answered as well. All right. So okay, so thank you very much, everybody. Let's give a round of applause again to Datin Dr. Asma, all right, for such a very enlightening and very enlightening and so at the same time so beneficial, right, and enriching session also this afternoon. And thank you again, Dr. Iliana, for organizing this, and thank you to all the participants for making the time for this very wonderful afternoon and for this very good session. Thank you very much again, everybody. Have a wonderful evening, have a good rest, and have a good weekend for those from the northern region. All right, and our weekend is coming for those in central region. All right, and okay, everybody, okay,
thank you, Zamri.
Thank
you,
Thanks
Jardin
for
Pharma.
supporting our product and services. Have a good day. Bye-bye.
Okay, so thank you, everyone. We will email you all the link again, and we will also let you all know via email the subsequent session sponsored by Jardin Pharma. Thank you so much for your time. Thank you for joining the session. And don't forget to submit the feedback form for CPD point submission, and don't forget to claim your free gift at the Herbitus app. Thank you, everyone.